This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine, published in 2026. It's titled Decompressive Craniectomy and Traumatic Brain Injury, Insights from a 15-year multicenter cohort in Sweden.
This is a timely paper, Laura. Decompressive craniectomy, or DC, remains one of the most debated last resort treatments in our field. For years, we've been trying to balance the immediate need to control refractory intracranial hypertension with the long-term functional outcomes of these patients. We've had the landmark RCTs, DCRA, and Rescue ICP, but how those trials translate into real-world bedside practice is often a different story.
Exactly. And that's what this study addresses. It's a retrospective, multi-center study, including 299 TBI patients who underwent DC between 2008 and 2022 across 4 Swedish neurosurgical centers. They looked at 15 years of data to see how practice patterns, indications, and outcomes have evolved, especially in the context of those modern RCTs.
Let's start with the demographics. Who were these patients?
They were largely who you'd expect in a severe TBI cohort, but quite young. The median age was only 37. About 76% were male. These were high-energy injuries. The patients were severely injured with a GCS motor score of less than 6, and nearly half, 48%, presented with unreactive pupils.
That's a very sick population. If half have unreactive pupils, you're already looking at a high risk of poor outcome. Now, what did the study find regarding the actual rate of the procedure? Did we see a massive drop-off after the DCRA trial suggested early DC might lead to worse functional outcomes?
Interestingly, no. The annual DC rate remained remarkably stable over the 15-year period. It declined only modestly from 3.6 to 3.2 per million inhabitants. What's even more striking is that the authors found that landmark RCTs appear to have had limited influence on Swedish DC practice.
That's a bold statement, but it reflects what many of us feel. The DCRA trial investigated early secondary bilateral DC for ICP over 20 millimeters and found functional outcomes were inferior to maximal medical management. Then Rescue ICP used a higher threshold of 25 millimeters and showed reduced mortality but increased rates of severe disability. The Swedish data shows that the proportion of primary versus secondary DC and the timing of surgery stayed largely unchanged over the study period.
There was one technical shift, though. The use of bifrontal DC decreased over time. However, the study highlighted significant regional differences. Even within a single country like Sweden, there was variability across centers regarding timing, specific indications, and techniques.
That's the art of neurosurgery clashing with the science. Let's dive into the radiological data. We know DC is excellent at physically creating space, but how did that look on the scans in this cohort?
The radiological improvement in mass effect post-DC was significant, with a p-value of less than 0.001. They measured things like midline shift and the state of the basal cisterns. Seeing the basal cisterns open up post-op is always a relief in the ICU. But as the paper notes, radiological improvement doesn't always equal clinical recovery.
Let's talk about the complications. DC is not a free procedure. You're trading a pressure problem for a whole host of other potential issues.
Right. In this cohort, reoperation for hemorrhage occurred in 10% of cases. Then you had complementary decompression, surgical site infections, and subdural hygromas, each occurring in about 5% of patients. And of course, we can't forget that these patients all require a subsequent cranioplasty, which brings its own risks of infection and bone flap resorption.
And that brings us to the most important metric for our listeners, the outcomes at 6 months. What did the Glasgow Outcome Scale, or GOS, show?
At the 6-month mark, 60% of patients had what we define as an unfavorable outcome. However, only 11% were deceased.
Wait, 11% mortality? That's actually quite low for a cohort where nearly half had unreactive pupils and everyone had refractory ICP.
It is. The authors noted that these real-world outcomes were actually more favorable than those seen in recent RCTs and other types of acute brain injuries. It suggests that our patient selection in clinical practice might be capturing a group that survives at a higher rate than the study populations in DCRA or Rescue ICP.
Or perhaps the Swedish model of neurointensive care is optimized for these patients, but we still have that 60% unfavorable outcome rate. Did the study identify specific predictors that could help a resident or an attending surgeon decide not to operate?
Yes, they identified several independent predictors of an unfavorable outcome. Higher age was a big one, as well as a lower initial GCS. Comorbidities also played a significant role. Radiologically, obliterated basal cisterns and impaired pupillary reactivity were the strongest predictors of a poor 6-month result.
It's the same unholy trinity we always look at: age, pupils, and the cisterns on the CT. If you're 70 years old with fixed pupils and no visible cisterns, the data here suggests that even if a DC saves your life, the chance of a meaningful neurological recovery is slim.
Exactly. The study emphasizes that DC should only be considered after exhausting less invasive options, but not to the extent that you allow further secondary brain injury to develop while waiting. It's that sweet spot of timing, not too early as to be unnecessary, but not so late that the brain is already infarcted.
One of the most interesting parts of this paper for me was the discussion on primary versus secondary DC. Can you clarify how they defined those?
Of course. Primary DC was defined as the procedure performed during the initial evacuation of a traumatic lesion, like a large subdural hematoma, because intraoperative brain swelling prevented the bone flap from being safely replaced. Secondary DC was the last resort procedure done later, usually in the neuro-ICU setting when medical management failed to control the ICP.
And the study found that the ratio of these two didn't change much over 15 years?
No, it remained stable. It seems that despite the debate surrounding secondary DC for refractory ICP, the clinical need to leave the bone out during an initial trauma craniotomy remains a common and necessary judgment call for the surgeon on call.
It's a testament to the fact that while RCTs provide a framework, the individual patient's physiology in the OR often dictates the move. If the brain is herniating through the craniotomy defect, you aren't going to check the DCRA exclusion criteria, you're going to leave the bone out.
True, but the paper does conclude with a call for more standardization. They noted that since practice remains variable across centers and doesn't strictly follow the RCT evidence, we need better ways to prognosticate. We want to avoid prolonging survival without meaningful neurological recovery, as they put it.
That is the ultimate fear in neurosurgery. We have the technology to keep the heart beating and the ICP low, but we have to ask if we are returning a person to a life they would want to live.
The authors also mentioned that DC in children was included in their analysis, though the majority were adults. They found that the general principles held, but obviously the regenerative capacity of younger brains always factors into our decisions.
So, to summarize for our residents listening, decompressive craniectomy rates are stable. Real-world mortality might be lower than RCTs suggest, around 11% in this cohort, but the price is a high rate of severe disability. If you're looking for prognostic red flags, look at age, the GCS motor score, and those basal cisterns.
And don't forget the complications. 10% will go back to the OR for a hematoma, and 5% will get an infection. It's a high-stakes surgery.
Excellent summary, Alara. This Swedish cohort gives us a very grounded 15-year look at what we actually do versus what the trials say we should do.
It really highlights the gap between controlled trials and clinical reality.
Well, that's all the time we have for today. For our listeners, make sure to check out the full paper in the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine for the detailed Kaplan-Meier curves and the multivariate analysis.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Until then, keep those cisterns open. This is Dr. Aris.
And Dr. Alara. Goodbye.